So my name is Philip. I am a behavioral scientist at the Desmond Tutu Health Foundation in Cape Town at the University of Cape Town. I have focused on behavioral economics in limited resource communities with the aim of improving health-seeking behaviors, particularly in populations that are hard to reach, young men and adolescents. I'm going to be presenting the TRACE study, transmission of COVID-19 in crowded environments. So the first South African SARS-CoV-2 infection was recorded on the 5th of March 2020, and the South African government implemented non-pharmaceutical interventions, physical distancing, sanitizing of hands and surfaces, and masking. So MPIs are difficult to implement in low resource communities for reasons that have been discussed at length at this conference. And at the time that we implemented the study, almost 40% of antenatal patients visiting government facilities across the country had antibodies. That was September 2020. And reviews indicate that households are the primary setting for infection, ranging from 4 to 55% secondary infection rates. So our questions were, what is the transmission timing of infection of SARS-CoV-2 in household settings with an index patient? And can an intensified infection mitigation intervention reduce transmission in a household setting? So the aim was to measure the frequency and timing of transmission. And our second aim was to investigate the effect of a package that we called STOP-CoV to prevent onward infection. So our methods, we conducted the study in a densely populated community in Cape Town, Klipfontein Mitchell's Plain. We used purposive sampling to recruit patients with SARS-CoV-2, and we included participants 12 years and older, and they gave consent if they were under 18 and consent if they were over 18. So our process was we received those referrals from Department of Health clinics. We then screened informed participants who wanted to take part and randomized them over the telephone. We conducted a household visit with a nurse and a counselor, and then the STOP-CoV team visited the households, which was comprised of community health workers. That STOP-CoV pack looked like this. It was a community health worker who delivered the pack and PPE at baseline, which included masks, hand sanitizer, and surface sanitizer. Those community health workers communicated with intervention households daily in their first week, and then every other day in weeks 2 and 3, and then once in week 4. Those community health workers delivered hygiene information, they monitored symptoms to prevent onward infection, and they identified those at risk of severe infection and referred them for care if required. So that's a picture of the STOP-CoV team. So the study looked like this. There were 120 clinic referrals, and they were randomized to either the intervention or the standard of care. We conducted household enrollment of the telephone and conducted a baseline visit plus 4 visits thereafter. This is a list of our activities. We did COVID serology with index patients, and then PCR testing and COVID serology with household contacts. Our study ran from the post wave 1 until wave 3 in September 2021. So 552 patients were referred to us. A quarter of those refused. Almost half of those were uncontactable. A few were ineligible, and a small percentage were previously enrolled in the study. So we consented and randomized 114, and 81 of those actually had at least one household contact, so they were with their household contacts included in the analysis. So this is a complex slide. The only thing that I'm going to say about this is the age differed in the intervention and control among index patients. Intervention STOP-CoV patients were slightly older than those in the control. So you'll see here at baseline, we had quite high levels of antibody serology in household contacts. And then just to summarize our results, the change in PCR incidence, there were 4 in the intervention versus 2 in the control, so 3% and 2%. Baseline serology was quite high in the intervention group versus the control group. And the serology change, there were 11 changes in the intervention group and 9 in the control. And then serology over 4 weeks, antibody reactive, 47% in the intervention and 25% in the control. And you can see that there was no difference in PCR testing and serology testing in the 2 groups. This is interesting. So 12 participants in the intervention group were referred for care. And you can see there that was for TB screening, COVID symptoms, ARV care mostly. And what we found was that 47 of those households in the control group required referral for food support. So there were high levels of antibodies detected at baseline. Infection spread before the trace team could contact the household. And track and trace and household measures did not, in this study, mitigate infection. And so we recommend vaccination for those who had highest risk of mortality and severe illness as a preventive measure. The limitations. So as said, there was a high rate of antibody reactive serology at baseline. Participants, so here's the nub, were referred to us 5 to 14 days after testing SARS-CoV-2 positive, and that's far too late to mitigate infection. And there was also a high proportion who declined participation. So I think the takeaway from this is that the value was in community health workers supporting families at their homes, detecting illness, and then referring them to clinics during lockdown. Thanks very much, and thank you to the research team.